So Zara, once again, thanks a lot for talking with us from Brazil. We read your article, your letter to the editor in neurosurgery about scope-based surgery in this time of the COVID-19. The first thing we'd like to know is you only perform urgent endonasal surgeries. Do you think it's not safe to do elective surgery even if the patient tests negative? What is your position now? What's you are doing there in Stanford about the elective cases, or you're only doing urgent cases? And I'm asking that because here in Brazil, we're starting to have a little bit of pressure, especially from the private hospitals, to start doing again the elective surgeries. And I want to know what's the current situation in the US.
Yeah, so it has changed is the answer from when we first heard about the risk to us as providers and as surgeons, and as the pandemic sort of increased over time. And now we feel like, especially here at Stanford in Northern California, we've been really lucky that the population has been very good at staying home, sheltering in place, and not interacting with each other. And so our rate has really flattened. We have flattened that curve very well. And now we're looking like maybe we're on the other side of that curve. And so what we did at the beginning is different from what we're doing now. So I'll just start from what we started at, because I think you guys are maybe a little bit behind our trajectory as far as the number of cases and when your peak is going to hit. I don't know if it's already hit or if you're still getting more cases now. But so when we first started to understand the possible risk of these procedures, we really shut down all elective surgeries. We really were only doing surgeries that were urgent, meaning people with cancer, so sinus cancer cases that, obviously you need to move forward and address cancer. And then pituitary or other skull-based types of tumors, if they seemed that they were an immediate risk to someone's vision or other, immediate complication type of thing. Even the tumors that had long-term visual loss, like over several months, they had been losing vision. Even those cases we stopped at the beginning because it didn't seem like a month of waiting would make a big difference. So that's what we did then. And we kind of held at that for about a month. But at this point now, since we're kind of coming down on the other side of that curve, we are starting to open back up for elective cases. But the way in which we're opening up is very specific. So, all surgery that happens now at Stanford University, all patients, regardless of the specialty, otolaryngology or general surgery or any other type of surgery, all the patients are getting a PCR COVID test 48 to 72 hours before the surgery. And then in addition to that, specifically for our endoscopic sinus and skull-based cases, those patients are getting a second test the morning of to confirm that, yes, they still are negative. And as long as they have 2 negative tests, we are opening back up for elective cases at this time. Now, this is really the very first week that we're doing that. And so keep in mind that it was about, 4 to 6 weeks where we were only doing urgent and emergent cases before opening back up. And it's really only because the very, very low prevalence now that is in the Northern Bay Area that we feel like this is okay for us to start doing.
Okay, and on these cases that you have the 2 negative tests, you perform regular surgery, or do you have N95 and all the protection equipment?
We're still using N95 masks and a face shield because, the thing is that with all these tests, even really good tests like the Stanford PCR test, there is some amount of false negative rate. And so, to sort of hang your hat on that test and not protect yourself does not seem wise. And so we are still using N95 masks and a face shield for all of those types of procedures. If the patient actually tests positive, then we really try to delay. We really try at all costs to delay the surgery. If it's an emergency surgery and either the patient tests positive or we simply can't wait to move forward and we just have to move forward before we have the answer of what that test is, that is when we consider PAPR use, the whole, powered air purifying respirator, which honestly in our whole skull-based team, we've only had to do that once in this last 4 to 6 weeks. But when we had to proceed without knowing the results of a test, that is what we used.
Okay, thank you. One of the things that I find very interesting when I read your article in neurosurgery was that when the patient tests positive, now talking about skull-based surgery, then you would prefer to do a transcranial approach if possible. And then my question is, and even if the patient does not test positive and thinking about this false negative tests, do you think we should always prefer a transcranial approach when it's possible?
I don't think so, because a lot of factors weigh into this. So I will say, a lot depends on what is the false negative rate of the test that you're using. So the PCR test at Stanford actually has a very low false negative rate. It's only 4%. There are other PCR tests out there across the United States and in the world whose false negative rates are very high, 30 to 40%. And so I think a lot of your decision making has to be based on how good is the test that you're using. Now for us, if we get those two negative tests, the benefit of doing a surgery endoscopically really seems to outweigh the decreased risk of a transcranial procedure for almost all our surgeries. I think that we really reserve that transcranial route at this point for a positive patient who really needs the surgery emergently, and it would be the same outcome, transcranial approach versus endoscopic approach. But we have not done any surgeries transcranially where we think that the patient would have a better outcome if we did it endoscopically.
Okay, great. On your letter to the editor in neurosurgery, you cited the Wuhan cases, especially that case that contaminated a lot of people. And then I'm wondering, after that, did surgeons from other parts of the world refer to you quoting or telling cases similar? What do you think, since you are in contact with surgeons all around the world? Is it common to have that kind of contamination?
Well, I think and first of all, regarding that first case, people started talking to me, asking me, were those providers infected in the surgery room or were they infected after? Because a lot of the reports in the official Chinese media said that it was only after. And so we did a lot more research into that case. We had our contacts in China speak to many, many surgeons in that hospital. And really what came to be very clear is that there is a lot of complexity in the way that our Chinese colleagues have to communicate what's going on or what was going on at the very beginning of this crisis. There are many different things at play, not least of which is the political situation in China and the ramifications of communicating about these types of cases and the whole process that was going on at that time. And so knowing that, we did look for any other cases that we could find out about. And we did hear about another case in China also. Again, it was very early on in the entire pandemic. And so we don't actually know a lot of the details about, were the masks properly fit and things like that. But what we also wrote in that same article was there was another case from another hospital in China where a patient who was known to be positive had to undergo emergency surgery for skull-based surgery. And the person that was wearing a kind of homemade PAPR was okay. And these other providers in the room that were wearing N95s became infected. And so there did seem to be at least one other case that confirmed that concern about the infectiousness of this type of disease in a skull-based procedure. Now, the one good thing that I think has come of that letter that we put out is that as soon as that became widely circulated, and it became circulated in email form way longer before we actually published it officially, I think otolaryngologists and neurosurgeons around the world were very quickly able to convince their hospital administrations that they needed a high level of PPE for these cases. And so then everyone using an N95, I think has hopefully, we'll find out soon when more data is collected, but hopefully has actually decreased the risk that these providers are encountering.
Okay, thank you. Do you? That's a question that one of our friends, Leonardo Balsalobri, that worked with Professor Aldo Stam, he asked me to ask you. I think it's a very interesting question. She said, "Do you believe that simpler endoscopic transnasal surgeries like midline pituitary adenomas could be performed if you do it without a drill, like using a keysil or something like that? Do you think it would be safer, and maybe we can start doing that sooner?"
Well, I think that is a good question. And, you know, we have discussed this a lot in our own skull-based team here at Stanford. And what conclusion we have come to is that when we use a drill, it is really not just for convenience sake or for making the surgery faster, but it really is the most appropriate tool for particular parts of skull-based surgery. Now, for this specific instance, when it's very midline, it's just in the sella, yes, you know, maybe you don't need a drill at all, I think, for those types of cases. But for anything that you need access to the carotid arteries, to the nerves around, to really make sure that your surgery is going to be complete and it's going to be safe, often a drill is necessary for that type of procedure. And so in the same way that, you know, we're not doing transcranial procedures when an endoscopic procedure would lead to better outcomes, in the same vein, we are using a drill when we know that using a drill would lead to the best outcome. We don't want to lower our standard of care based on this potential risk that we really don't know, and we don't have a lot of data yet about. We really just have a lot of anecdote. And so right now we are not lowering our standard of the way in which we would approach these cases, but we are making sure that we are protecting ourselves while we're doing that with appropriate PPE.
Okay, great. And going a little bit out of the scope-based surgeries and talking about rhinology normal cases, especially the use of microdebriders, because we know the drill increases the risk of aerosolization and the risk for the surgery team. But do you think microdebriders would increase this risk too, or are they safe to be used? Would you prefer to use only cold instruments in this time?
So, so the answer is we don't know, but I'm doing a study. I'm collecting the equipment that I need right now to do that study to answer that question. We were talking a little bit, Tiago and I were talking a little bit before we started this about that same question. And, you know, the Ben Blyer and his group out of Mass Eye and Ear, they just published a study trying to answer this question. The problem, and so in their study, what they found was that high-speed drilling did seem to create more particles than these other types of instruments, microdebrider, cold instruments, or just a scope. The problem with that study is that they were only able to detect down to 5 microns. And 5 microns is really much larger than these viral particles, right? COVID-19 itself is carried in 0.3 micron particles, aerosolized particles. So we really don't know from that study whether or not these procedures are aerosolizing, because when you set a filter down on a surface like they did and just see what comes onto it, that's a droplet. That means that it was heavy enough to fall and sit on the paper. But what we really want to know is, what about those particles that are small enough that they just stay in the air around our face, around in the office room, in the OR? What is happening, and which particular types of instruments or procedures are creating that? So I'm about to do that study, and I will definitely let you know as soon as I know. But uh, as far as the question is, as of right now, I am not changing my practice as far as which instruments I'm using. Again, I don't want to lower the standard of my surgery just because of this potential risk. I'm simply using the correct PPE, continuing to operate the way I normally would, and hopefully soon we'll understand whether I really need an N95 mask when I'm just doing a sinus surgery versus just being able to use a regular surgical mask. Hopefully we'll have that answer soon.
Thanks a lot. And well, going a little bit now out of surgery, and since you are probably one of the top researchers in olfaction that in the rhinology world, what do you think about this, the sudden anosmia that is being very common in the COVID-19? We've been doing a survey here in Brazil, all ENT doctors in Brazil that have patients with anosmia are sending this data to us at the Rhinological Society, and so we're collecting that, and there's a lot of cases, and I
Yeah.
bet you are seeing a lot of cases too. Uh, could you find some specific characteristic of the anosmia of COVID cases? Is it different from other post-viral anosmias? Is there a time that usually the patient recovers? Did you already have some thoughts about that?
So those are all great questions, and the answer is we don't know. So, there has been actually already quite a few publications about the smell loss related to COVID-19. And the things that we do know is that it could be the very first sign of a COVID-19 infection. It could be a sign that happens anytime, even after other symptoms have already occurred. It could happen early, it could happen late, or it could be in a totally other asymptomatic patient, the only sign of COVID-19 infection. And so there really is no link to, when it presents. And the other thing is that, some people early on started saying, oh, people seem to recover pretty quickly within a couple weeks. Some people are getting their smell back. But when you actually look at the numbers that have been put out there, it doesn't actually seem better or more encouraging than other post-viral losses that we have seen before this pandemic. Obviously a whole lot of other coronaviruses and rhinoviruses and influenza viruses also can lead to post-viral loss. And this does not seem to necessarily have an improved course. I think the same things that dictate recovery in COVID-19 are the things that have always dictated recovery. For example, the age of the patient, how many comorbidities the patient has, and the duration of loss before you try to start any sort of intervention. So I think those are the main determining factors. I just reviewed a paper that was submitted that has not been published yet, but they cited something along the lines of 50% of patients with COVID-19 at about a month out seem to have recovered some amount of loss of smell and taste. And that's pretty typical, I think, for all post-viral losses. That's not a better number necessarily than other viruses that we see.
Yeah, I think that one of the few good things that we may say that came out of this pandemic is that people are paying attention in olfaction for the
That's
first
true.
time.
I've never been asked so much about olfaction before.
This year, for the first time, we see in the newspapers and in the
Yeah,
internet people talking about olfaction. And one of the
exactly.
things people discovered olfactory training.
Yes.
And one of the things they ask a lot is when should they start? Like the
Yeah.
patient with, I think what we are seeing is that most of them recover completely. But to
Good.
the ones that do not recover completely, how much time after the infection do you think they should start the olfactory training?
I would start it as soon as possible. There's really no downside to starting olfactory training. It's very simple and easy for patients to do. The only thing it takes is their time. There's no side effect. There's no risk. There's no reason not to do it as early as possible. And so I encourage all of my patients to start it right away if they can.
Okay. Well, Zara, thanks a lot for talking to us. We here, the rhinologists in Brazil, appreciate it. We thank you a lot.
Of course.
I hope that you keep doing the great work you've been doing. Be safe, and we hope to see you in Brazil as soon as possible.
I hope so too. You be safe too. Thank you so much for having me. And I would love to come to Brazil whenever I can.